In this video, we're going to go over bariatric operations that are commonly performed, and this is how I explain them to my patients. My name is Dr. Vella, and I'm a bariatric surgeon. So commonly, gastric bypass, which is actually the oldest, most well-studied procedure out there for bariatric surgery, is a metabolic operation, meaning it affects hormones that regulate appetite and how our body perceives needing food. So appetite regulation, hunger, satisfaction from meals. These are the hormones that gastric bypass affects. The SADY, or the single anastomosis duodenal ileal bypass, that's a very big mouthful, which is why it's abbreviated SADY. It's essentially a sleeve within a loop of intestine brought up and sewn just beyond the pylorus. This is an anatomical location at the bottom of your stomach. But what this does is it creates a 3-meter-ish long segment of what we call common channel. So common channel is where your body is then getting food and digestive enzymes all at once. And so about 3 meters of small intestine is the absorptive area of your food and calories. This procedure, the SADY, it's not something I yet commonly perform because it's not widely accepted by most insurances here in America, but it is definitely growing in popularity and showing itself to have similar short and long-term complications as, say, the gastric bypass, with more dramatic effects in terms of reversing metabolic disease. So type 2 diabetes is one of the main things that I ask people to consider coming into bariatric surgery. If you have type 2 diabetes, I would encourage you to heavily consider gastric bypass or maybe something like the SADY if that's an option to you. A SADY has about a 70-ish% ability to reverse type 2 diabetes. A gastric bypass is around 40%, and a sleeve gastrectomy is closer to 20%. A sleeve gastrectomy is another procedure that I commonly perform, and those sleeve gastrectomy and gastric bypass is really what we're going to be talking about today, comparing the two operations. How are they different? How are they the same? And in other videos, we talk about their complications. So the mechanisms of weight loss surgery really are hormonal changes and restriction. Both or all of these operations offer restriction. Restriction is making your stomach smaller, so you physically feel full from that physical sensation. I always like to warn people, though, the stomach is a muscle and it will learn to stretch to accommodate bigger meals the further away from surgery you get. This does not mean that your stomach grew back. You didn't stretch out your pouch. After those meals, the pouch gets small again, but your awareness and your sensitivity to what it feels like when it stretches, that does change. So we can't necessarily do surgery to make the stomach smaller after we've already given somebody a bariatric operation. The hormonal changes are present in all of these forms of surgery, the sleeve gastrectomy, the SADY, and the gastric bypass, but the hormonal changes are broader when you bypass the first portion of the small intestine. So the gastric bypass and the SADY both have more hormonal mechanisms, which can further help a person lose substantial amounts of weight, maintain that, and also regulate hunger, appetite, and blood sugar. The gastric bypass, we have restriction in our pouch. The pouch is about 2.5 inches wide, 2.5 inches long. And then the intestine, because the intestine is divided and then brought up to the pouch, you are bypassing, again, the duodenum. Bypassing the duodenum seems to have the biggest impact on our reversal rates of type 2 diabetes. So these operations promote becoming sensitive to insulin, which is the opposite of type 2 diabetes, which is the hallmark of insulin resistance. So I'm kind of throwing out medical jargon here, but if you are a person who personally has diabetes, these are words that you have heard from your providers. These are probably things that you're now well versed in. Gastric bypass does a pretty good job at reversing this. And again, the SADY does an even better job. The sleeve gastrectomy also focuses on restriction, but instead of a small gastric pouch then connected to the intestine and we're bypassing the duodenum, if my cursor is working, is right here where the tube or the conduit from the gallbladder is coming into the intestine. That's the duodenum. It's the first portion of our small intestine. With the sleeve gastrectomy, we don't bypass that. And I say this is also a big advantage because it is beneficial to leave digestion intact. When we can chew our food, have it reach our stomach in a sleeve gastrectomy or SADE still makes stomach acid. And you need stomach acid to digest your food, absorb protein, etc. But with a sleeve gastrectomy, that food then enters the duodenum. So these procedures, I think, are some of the better ones for people who don't have type 2 diabetes or for people that don't think they're a good candidate for bypass or SADE. And we'll get into that into our complication videos, but there's some very specific lifestyle things that people need to be aware of before they start making the choices to reroute their intestines. Ulcers are pretty common. Internal hernias are really common. And then the risk of vitamin and mineral deficiencies goes up significantly. So smoking is not a good idea with any of these surgeries, but especially those where the intestine is sewn to the stomach. Ibuprofen is another thing. You do not want to take ibuprofen in the gastric bypass, and the SADE operations are pretty sensitive as well. You're going to get ulcers where the stomach and the small intestine are sewn together. The sleeve gastrectomy is a great option for people that feel like those medications are something that they can't live without. You still get wonderful restriction, and there's still hormonal changes. In fact, ghrelin, which is our primary hormonal or hunger hormone, that is largely produced by the stomach. There's other ones produced by the small intestine, which is why the other ones have even better rates of remission. Remission doesn't necessarily mean cure. It means that you're no longer displaying symptoms, or it's kind of like how cancer can then go in remission. It's not that you're totally cancer-free. It might come back, but for now you're safe. So that's how we talk about type 2 diabetes and some of the other metabolic conditions that so many people with obesity face. So here are the similarities, and I think this is really important for everybody to understand. All of these surgeries require dietary and lifestyle changes to make the tool work for you. All of these procedures require bariatric vitamin and mineral supplementations. We recommend Bariatric Advantage multivitamins. They are our best-selling vitamin in our clinical practice and on our online practice. They're just much more easier to take, much more palatable versus some of those really chalky, chewable kinds. It is important, though, that especially with the procedures that reroute the intestines, that you're taking these vitamins every single day. The sleeve gastrectomy, because the whole stomach is intact and then digestion and absorption is left intact because we don't reroute the intestines. That one, you can still get vitamin and mineral deficiency, especially in that first year when your diet is so limited. As time goes on, though, trust that what you are taking in is being absorbed. So you might not necessarily need those big whopping doses of bariatric vitamins. However, if you are supplementing with the bariatric vitamin consistently, you can rest assured that you're very, very unlikely to get a deficiency. All of these procedures necessitate chewing your food very well, eating small bites, and then swallowing slowly. And that is because of the restrictive element. So regardless if you're having a bypass, a sleeve, or a SADE, it's really important that you practice these behaviors in and around eating so that you can have the best mind, body, stomach connection after surgery. Recovery from surgery is the same. And it's the same as long as everything goes well. It's roughly the same number of incisions, depending on who your surgeon is. And the time it takes in the hospital for recovery should be about the same. Now, there are nuanced differences on the types of complications that can happen. Leaks can happen anywhere there's a staple line or a new connection. And because the sleeve, the SADI, and the gastric bypass all use surgical staplers, then leaks can happen on any of those. Good news is, depending on your surgeon's hands, the national and international rates of leaks is quite low. So it's not something I would necessarily worry about. With complications, though, it always just comes down to being able to be safe or feel safe in your surgeon's hands and in your hospital's hands, because you're going to need a good surgeon, a good hospital to take care of you if these things occur. Like I said, number of incisions is the same. Short-term complications are similar. I'll just expand on that. Bleeding, leaks, deep vein thrombosis, like a blood clot in your leg, or an MI, like a heart attack. In my practice, we have every single person exercise multiple days a week to really help prevent blood clots after surgery. The better in shape you are before surgery, the easier it is to get up and move around after surgery. But also, the more you exercise, even if it's just going for a quarter, a half a mile walk every day, you're going to really test your body. And as long as you're not getting chest pain, the likelihood of you actually having a major heart event in surgery is quite low. Infections, skin infections, things like that, need for another surgery. So here's where gastric bypass and both the SADIs have a slightly higher increased risk of needing another operation, simply because the long-term complications are so much more, involved. Ulcers might need another surgery or an upper endoscopy to diagnose that. And then also the bowels kinking, you can get narrowing of the connections. It's called stenosis. So there's things that can happen like that are kind of unique to, again, intestinal surgeries. Vitamin deficiencies for both. Gut imbalances. We have a whole video on how your gut health is really important pre and post surgery and what you can do about it. That's really the whole hallmark here of Art of Bariatrics, is taking care of your body from the inside out. And then death. I say death with a little asterisk because we are seeing as a trend death from these surgeries go down, down, down. So it's becoming rarer and rarer. And I think a lot of that is because our surgical techniques broadly are getting really good. They're getting really uniform. Basically, surgeons know what they're doing, which is fantastic. And then lastly, we have a higher expectation of the health of a person coming into surgery. So I operate at a nationally accredited bariatric center, and the national rate of death from any sort of surgery-related complications is 0.07% now. It's believed that bariatric surgery is now safer than a routine gallbladder operation. So your ability to put one foot in front of the other, no pun intended, but to exercise, to eat well, and to really start implementing what you practice before surgery is what's really helping in dropping these overall complication rates. And that's it. On to the next video.